Today we will learn about surface anatomy of lungs, because in exam setting or when you are auscultating and percussing for lung examination, many doctors and postgraduate residents, they commit few mistakes. They need to have very clear idea which areas of the lungs they are examining, whether this is apical area, upper lobe, middle lobe, only on the right side, or lower lobe on both sides. Area of cardiac dullness that need to be avoided, because you are not going to get any information of lung pathology while auscultating or percussing on the cardiac area. Lungs are covered by parietal pleura, and then it is encased by visceral pleura. So we will be talking about parietal pleura first. So let's start with the apical region. This is clavicle. Clavicle has sternal head and acromial head, and if we divide it in three parts, this is medial 1/3 of the clavicle. It's roughly about 2 to 3 centimeter above the medial 1/3 of the clavicle, where the apical surface of the lung is located. In adults and in older children, this is precisely around 2.5 to 3 centimeter, but in younger children, this may be lower than that. We will draw a line to manubrium sterni, which is second costal cartilage joining the manubrium, and behind this is the second intercostal space. So you have to keep in mind few figures, which is 2, 4, 6, 10, 8 and 12. That will help you a lot. So on the second costal cartilage or manubrium sterni, here is the second mark. Third mark I will be placing at the level of fourth costal cartilage. So this is second, third costal cartilage, and this one is fourth costal cartilage. In the center I put a mark. We will draw a line starting from the apical area joining second costal cartilage till fourth. So this is straight line, same on right and left side. A parietal pleura is reflected like this. Now I will mark sixth costal cartilage. We need to ascertain first where is heart, and we all know that apex beat of the heart is precisely in normal child around 1 centimeter in the mid-clavicular line, and it is in fourth or fifth intercostal space. In older children generally it's fifth, while in younger children this may be fourth intercostal space. And in our case, apex beat is here at the fourth intercostal space, 1 centimeter inside the mid-clavicular line. From third costal cartilage, the heart area would start, the base of the heart start here, so I will put a red mark here. From fourth costal cartilage, there is a recession or dip in the pleura, as it is reflected laterally, and it gives us space. So first, if we draw, the heart will come like this toward sixth costal cartilage. Then it will extend in a little curved fashion. This is right ventricle which is making the heart basis, and it goes toward apex. From apex, the heart will again go to the base, which is lateral border of the heart, being found by mainly left ventricle, and in the upper part there is a little component of the left atrium. This whole right wall of the heart is being found by the right atrium. So you can see that from third space onward, we shouldn't percuss on this heart area, area of cardiac dullness. Next, point out xiphisternum, which is the lowermost part of this sternal area. We can just mark it like this. Here is the sixth costal cartilage, and we will be joining this line of sixth costal cartilage. From sixth costal cartilage, the parietal pleura will get reflected and will go to the eighth costal cartilage at the mid-clavicular line. Now let's calculate where is eighth costal cartilage and then the space following it. This is second costal cartilage and space, second, third, fourth, fifth, sixth, seventh and eighth. So here this is eighth costal cartilage and the space. This parietal pleura will move laterally to the mid-axillary line. This is mid-axillary area, whose anterior border is being formed by pectoralis majoris and posterior wall is being formed by latissimus dorsi. How the right lung is being divided in three lobes? You will draw a line from the sixth costal cartilage, keep going through the mid-axillary line. As it is going back, the line of oblique fissure, as it started from the sixth costal cartilage, it's going through the medial border of scapula, which we will be shortly seeing while the patient will stand. Then this will touch third spinous process of the thoracic vertebra. So you can see that this has adopted an oblique course starting from anteriorly till posteriorly. For middle lobe, we will start a line from the fourth costal cartilage joining oblique fissure in the mid axillary area. Anteriorly, it's mainly upper lobe on the right side. Similarly, on the left side till third space, we will be at liberty to examine for the upper lobe, and then there will be area of cardiac dullness from the third intercostal space till xiphisternum or costal cartilage and laterally. Here what you can do, you can go laterally in the mid axillary line from the third space onward for percussion and for auscultation. If you see here, after the upper lobe, you will be actually examining middle lobe of the lung. Only small triangular area of the lower lobe will be visible on the right side, which can be auscultated. On the left side, only smaller segment, almost triangular in shape, is going to be presented. Anterior part, rest will be all examined from the posterior part of the chest. Following the course of oblique fissure, you can ask your patient to abduct and to raise his upper limbs. We will be following the medial border of the scapula, and it's almost at the superior border of the scapula, spinous process of third thoracic vertebra. This oblique fissure is precisely defining the upper lobe and lower lobe here. So middle lobe is mainly auscultable and presentable anteriorly and in axillary region, while here the area above this third spinous process is for upper lobe auscultation. Below till here, till 10th space, it's all lower lobe. So you can auscultate very well posteriorly for upper and lower lobe, and anteriorly for upper and on the right side middle lobe. The last mistake which we should not commit, this is central spine, and on the lateral side is scapula. There is no point in auscultation or percussion on the scapular region. So you are left with this much space, which I will talk about later in my respiratory system examination video, that you will be either percussing or auscultating in the paraspinal region for this area, and then below scapula you will be at liberty to auscultate or percuss in a bigger area. Thank you very much. If you have any queries or questions or comments, you can drop in the drop box. Next video will be respiratory system examination.